Welcome back. Today we are going to conclude the final session of recurrent implantation failure, and according to the recent worldwide guidelines, and that is based on evidence. And of course, here I would like to say that these have been done on scientific studies, and of course, some people may have their own personal experience. For example, we do recommend immune treatment in certain cases of failure. So having come back, so there have been certain green and certain orange and certain red recommendation by this group. So in the green, that the endometrium has to be as thick as possible. That is number one. Then if there is a genetic anomaly in the couple, then genetic counseling and genetic testing of embryo. And again, lifestyle factors have been taken up. Something that can be considered if there is infection, then we treat with antibiotics. Again, genetic testing and blastocyst stage embryo transfer. So coming to review of estradiol treatment, we need to build the estrogen as high as possible. And what we do in our center, if things are not picking up, we do a hysteroscopy, we monitor in a non-medicated cycle, we increase the oral dose, we change preparation to subcutaneous, we add substances like letrozole, HMG, and in adenomyosis and endometriosis, it has to be a downregulated protocol. Natural cycle is one of the best cycles for transfer. And if what we are all doing routinely is an HRT with estradiol valerate or estradiol hemihydrate, and like we mentioned, if things don't work, then you stimulate it with some medications and then prep the endometrium. There has been some work on PRP as well, and we have done it in a few cases with ambiguous results. The one or two cases have been positive. Whether they would have been anyways is a question, it's debatable. And also antitubercular treatment where there are thin endometrium recurrent failures is also to be considered. So you need to start the preparation on the right cycle, and then you have to monitor the follicular growth if there is any. And for progesterone should be given when the endometrium is thick or if there is ovulation. If there's any spotting or any fluid, please cancel your transfer. Ensure you have as good embryos as possible, a very quick atraumatic transfer. And then, of course, if after persistence things are not building up, then adoption, surrogacy, and all other things should be considered. For aneuploidies, especially in parents, if there is, then the genetic testing of embryo should be considered. So genetic testing of embryos is, this is the blastocyst, and we are taking the biopsy from the outer shell, and the inner cell mass is somewhere here, and this is where we are taking the biopsy. So there's a lot of debate whether this outer shell really represents the inner cell mass. And in conclusion, it is the consensus is like don't randomly keep on doing it for all cases, but where there is genetic anomaly in couples with recurrent failure, then definitely it is to be considered. Then 98% miscarriage rate was seen in embryos which were genetically abnormal. And therefore, this study concluded that definitely abnormal means abnormal, and therefore the normals have a higher chance of continuation. However, there have been studies which have transferred normal and got negative results, abnormal and got positive. But yes, in this study, this is what it is. And if you're doing your PGTa properly, then probably it will get you somewhere in such cases. So NGS-based pre-implantation genetic testing of aneuploid of trochoectoderm biopsy. This study, which was published in 2029, said that if you're doing it for recurrent implantation failure, PGTa, then your success rates will increase. And blastocyst is preferred in such cases. And of course, for blastocyst, you need 2 to 3 grade A embryos to reach to that stage. And of course, if you have fewer embryos, perhaps doing a cleavage stage transfer is better. And no evidence between, it's not that blastocyst has a huge pregnancy rate, but it has definitely better selection when there are more embryos. Again, the study said that blastocyst is better. Let's not forget the male factor, and in this, we need to modify the male factor. We need to be sure that they are not smoking, taking alcohol. We need to stop certain medication or change them to safer ones. So the male factor is an important point in the whole treatment algorithm, and taking care of the lifestyle, losing weight, changing or stopping medication, taking antioxidants, antibiotics when needed, hormonal treatment when the hormones indicate, uh, surgical retrieval of sperm in certain cases, IUI, IVF, ICSI, PGS. These are the various treatment modalities that can be offered, and uh, things that must be taken care while we are going through the male factor. In that, when there has been a male factor that has failed, we need to know what kind of sperm it was. Was it ejaculated or testicular? Was it fresh or frozen? And how was the quality? Was there DNA fragmentation? Genetic testing, was it done? Did we take a double ejaculate? Was it testicular sperm? So all these things need to be taken care of. Of course, things that are not recommended have come into vitamin D deficiency treatment, endometrial injury, GCSF administration, intralipid immunoglobulin, autologous intrauterine PRP, HCG, heparin, assisted hatching. It means that these have not had enough evidence to support in this huge evidence-based, scientific literature that we are discussing today. Having said that, we have had experience with heparin, IVIG, and we have given our presentations and publications in which we feel that in certain cases they are helpful, and we practice that. So there is no one size that fits all model, We cannot say that this is the case of recurrent failure and let's do this, and there'll be the pregnancy. Everything needs to be taken into consideration, and each patient is different. The circumstances, the multiple factors are different, and therefore need to be worked out accordingly. So optimization of all problems. So if there's a thyroid problem, if there's an immunity problem, if there's a uterine problem, So the attack on treatment should be from all sides, male side, female side, hormonal side, infective side, immune side, endometrium side, egg, sperm, laboratory, transfer technique. Then we will be able to get the result, hopefully. So this Optimum trial in which they did a study, and then they found that the possible risk factor was identified. For example, if there was chronic endometritis, it was treated with antibiotics. If there was overt or subclinical hypothyroidism, thyroxine was given. If there was thrombophilia, was treated with low-dose aspirin. And all these small things led to increase in pregnancy rate. So a wholesome look into each patient is necessary. The counseling in such couples is also very important. And we must provide time for questions, information, repeat if needed, listen to the facts and feelings of the patients, show respect for their choices, and use clear and sensitive language and avoid insensitive terms which hurt the patient, and try to be as calm and as comforting as possible. Of course, you need to be honest, be very clear about the likely outcomes, and do not give false assurances. Give the evidence, the benefit or the lack of benefit of certain tests and investigations. They should be further reassured based on their individual estimation of likelihood of implantation in the next cycle. For example, this we discussed in the first episode of this, that suppose this patient has a 60% chance of success only after 3 attempts, then adding a whole lot of treatments just before is not going to help. And this concept needs to be, understood by more and more IVF practitioners and need to be conveyed to the patients. This whole anxiety once the cycle gets failed, and this need to do something very different to get them the result next time, must be addressed both at the physician level and the patient level. Further support for this can be derived from a study showing that half of the patients with RIF achieve a live birth with ART within 5 years. So that's a long time, but even if you do nothing, many would just, of course, RIF will be when you have not achieved 60 despite these attempts, and many, conceive when appropriate treatment is instituted. So apply a shared treatment planning with multiple specialties with both the couples if needed. A multi-cycle approach could be beneficial, as it would consider cycle failure and how to cope with it from the start of the treatment process. Sometimes explaining to the couple right in the beginning and maybe telling them that, you may need 2 to 3 attempts, and let's not consider it a failure till you have really crossed through these cycles, is a good option and a good discussion with the couple. So just a quick recap, the investigations that are recommended are reassessment of lifestyle, reassessment of endometrium thickness, assessment of antiphospholipid antibody and antiphospholipid syndrome, karyotyping, 3D ultrasound, hysteroscopy, endometrial function testing, chronic endometritis, thyroid testing, and progesterone level. And in the intervention, make the endometrium good, genetic counseling, PGTa, optimization of lifestyle factors, antibiotics, blastocyst stage transfer. So bottom line, these are difficult cases with huge emotional load. So being kind, showing concern, empathy, compassion, by the treating team is important. Sometimes repetition is all that is needed without adding the burden of unnecessary tests and interventions. So thank you very much. I'll be happy to see your comments and questions in the comment section. Thank you.